It's really a pleasure and an exciting time to talk about giant cell arteritis. We're at the cusp of a new era in this disease, the advent of the biologic era in GCA. But what I'd like to do this morning is to start by discussing the current treatment strategies for GCA, and this will be a segue then to Dr. Merkel's lecture on use of biologics. We'll talk about disease chronicity, we'll talk about treatment-related complications, and also disease-related morbidity. So this is meant to be interactive, and we'll go through some cases. These are mostly centered around a patient, Mrs. Smith, and I'd like to get your thoughts on her management. So she's a 73-year-old white female who has had malaise and some proximal myalgias going on for several weeks. She then developed bitemporal headache for the last 3 weeks or so. She notices tenderness on her scalp, and she's developed some sores on her head. Yesterday, she noted the sudden onset of painless vision loss in her right eye. She came into clinic and had urgent labs checked. Her sedimentation rate is 36. Her CRP is 23 milligrams per liter. You recommend a temporal artery biopsy, and this is what she looks like on exam. She has significant scalp necrosis bilaterally over the temporal parietal areas. And when ophthalmology sees her, they see evidence of a pale, swollen optic disc concerning for ischemic optic neuropathy. So if you'd like to use the audience response system, I'd like to get your thoughts on how we should manage this patient. Should we give Mrs. Smith prednisone 40 milligrams to start with, methylprednisolone intravenously 1,000 milligrams, prednisone 20 milligrams, 60 milligrams, or intravenous methylprednisolone 100 milligrams? Please enter your choice. So this is a fairly typical patient with giant cell arteritis, except perhaps for the scalp necrosis, which is fairly uncommon, but at least in case series tends to be associated with ischemic optic neuropathy. And I see everybody agrees, or the majority agree, that the patient should receive intravenous methylprednisolone, others opting for 60 milligrams of prednisone a day. Really not a very clear-cut strategy, but I think most of us would agree on the pulse intravenous methylprednisolone. It's actually not based on a lot of solid data. But in terms of reviewing glucocorticoid use in giant cell arteritis, we know that they're effective, and they've been used since the first patient was treated with cortisone at Mayo in 1949. We know that patients' symptoms tend to remit, and systemic inflammation, as evidenced by the ESR and CRP, tend to drop quite rapidly with onset of treatment. We know that in the pre-glucocorticoid era, in the 1930s and so forth, vision loss occurred in up to almost 2/3 of patients with the disease. More recent data suggests a lower incidence of vision loss. There are a few clinical predictors, particularly jaw claudication, and interestingly, a high inflammatory response tends to be associated with a lower risk of vision loss. There are some hypotheses as to how this may come about, but the actual etiology is not clear. We looked at the prevalence of vision symptoms at the onset of GCA in Olmsted County. This is our local population-based cohort of patients with giant cell arteritis. And as we tracked these patients from the 1950s to more recent decades, we see that there has been a significant decline in the prevalence of vision symptoms at the onset of GCA. This is likely attributed to earlier disease recognition and earlier institution of therapy. Ischemic optic neuropathy is the most common cause of vision loss in GCA. In earlier decades, we saw an incidence of about 15%, but in more recent decades, it was closer to 6%. Obviously, we'd like to see this come down to 0, and this is one of the reasons that around the country and in the rest of the world, fast-track clinics for GCA have been instituted, because it's really not the amount of steroid, but just the idea that patients need to be treated promptly before the onset of vision loss. But there is some data, retrospective, fairly low-grade evidence actually, that high-dose intravenous methylprednisolone may be advantageous in patients with recent or impending vision loss. One strategy, of course, is to try to protect the contralateral eye, which is at risk. On the other hand, for most patients with GCA, in the absence of vision loss, 1 milligram per kilogram per day of prednisone is generally recommended, usually maintaining that dose for a month, and then with a gradual taper thereafter. Alternate steroids is not recommended, as it was shown in a clinical trial that there was a higher rate of relapse with that strategy. We do know, however, that glucocorticoids do not reverse established ischemic optic neuropathy. They may prevent progression if there is partial loss or recent onset of symptoms, and again, we want to protect the contralateral eye. As we said, timing is critical, and interestingly, it really boils down to starting the patients on treatment as soon as possible, because once you start treatment, the risk of vision loss, if there are no symptoms at onset, then the risk of vision loss is quite low. In one study at least, the 5-year probability of new loss of vision was only 1%. On the other hand, those who already had vision symptoms, then there was a more significant risk of ongoing progression. So Mrs. Smith, we're still following. She has a biopsy-proven diagnosis of giant cell arteritis, has been started on treatment, and now comes in for her 3-month follow-up visit. She's complaining of fairly typical glucocorticoid-related adverse effects, insomnia, weight gain, and hyperglycemia. Currently, she has no symptoms of GCA or polymyalgia rheumatica. Her inflammatory markers have improved as expected and normalized, and her prednisone is now down to 20 milligrams a day. While reviewing her treatment plan, she asks, well, how long do I need to be on these steroids? A very common question, of course. Certainly, the steroid-related side effects instill a lot of concern and anxiety, and understandably so. So she asks, well, how long do I need to be on prednisone? So following a diagnosis of GCA, what proportion of patients are likely to be off glucocorticoids after 2 years of follow-up? Is it up to 20%, 20 to 40, 40 to 60, 60 to 80, or 80 to 100? As you recall, most standard textbooks, expert review articles, etc., talk about treating patients for 1 to 2 years with glucocorticoids, but there's evidence in the literature to suggest otherwise. And most have answered C, 40 to 60. I would actually say that a lot of the data points to B, 20 to 40, and I'll show you some of that data. So this is a population-based cohort, again, Olmsted County, where Mayo Clinic is situated. And this shows the steroid use in an earlier cohort, 1950 to 1979, and then a more recent cohort, 1980 to 2009. And I'll take the more recent cohort, 80 to 2009, and in those individuals, at 2 years, only 38% were off glucocorticoids. The median time to discontinuation, to complete discontinuation of prednisone, was 2.5 years. In a more recent study, now this is a referral population, patients referred to Mayo Clinic for evaluation and treatment of giant cell arteritis, so perhaps there is a referral bias, but it's a very large cohort of 286 patients, and in this cohort, just published last year, there were only 1/4, so 24% of patients were actually completely off glucocorticoids at 2 years, and half were off glucocorticoids at 5 years. Now you could say, well, we're over-treating patients, but really this underscores the notion that GCA is a chronic vasculopathy with, unfortunately, recurrent relapses and often a requirement for long-term use of generally low doses of glucocorticoids. But it's not easy to get patients off treatment. One of the aspects we wanted to address is, of course, as you know, there have not been good prospective clinical trials evaluating the optimal starting dose of prednisone in people with GCA. So we tried to look at, retrospectively, individuals who are started on more than 40 milligrams. Again, the standard is 40 to 60 or about a milligram per kilogram per day, but some patients got more than 40 and some patients got less than 40 milligrams as a starting dose of prednisone, and we wanted to compare these two. And it turns out that in the lower dose range, patients got about 0.6 milligrams per kilogram to start with, and then the others got about 1 milligram per kilogram initial dose. When we looked at what happens to these individuals over time, it was interesting that actually the individuals receiving more than 40 milligrams, so about a milligram per kilogram per day, even though they received a higher dose initially, they were more likely to discontinue prednisone earlier actually than those who were started on a lower dose. So somewhat counterintuitive to what we would think, let's start the patient on a lower dose to try to spare glucocorticoid side effects. But this data, at least in this one study that's retrospective with its own limitations, but it suggests that perhaps a higher dose early on, or at least a standard milligram per kilogram per day early on, may lead to a shorter overall treatment course. Again, data that needs to be replicated in other cohorts. So we recognize the limitations of glucocorticoids. As I said, GCA we now know is a chronic vasculopathy that does not easily respond to treatment. A lot of patients experience disease relapses. Almost all of them experience treatment-related morbidity. And then we often encounter vascular complications, arterial stenoses, and/or aneurysm formation. So steroids are not the answer. Connie Wine and her group at Stanford has shed some light as to why this is. And she's shown that there are two main immunologic pathways in GCA. One, the Th17 pathway, and the other being the Th1 T cell pathway that produces gamma interferon. And in elegant studies using murine models implanted with human temporal artery samples, she was able to show that glucocorticoids are very good at abrogating the Th17 T cell pathway, but often leave the Th1 pathway unchecked. And this may be one mechanism whereby chronic vasculitis persists in GCA. So we obviously need better therapeutic strategies. Another interesting study that was reported recently, performed at Mayo by a retired ophthalmologist now, Brian Young, Connie Wine, and colleagues, and this is a prospective, what we call the second biopsy study. And basically what they did was they took 40 patients with biopsy-proven GCA, so this is biopsy at baseline, 100% all positive, and they randomly assigned patients to come back at 3, 6, 9, or 12 months for a contralateral biopsy. All patients were treated according to standard medical care with high-dose glucocorticoids and a standard taper. What was interesting is that at 3 months, 70% of biopsies were still positive, about 75% at 6 months, 44% at 9 months, and 44% at 12 months. And these were, again, reviewed in a blinded fashion by a specialized cardiovascular pathologist and were diagnostic of arteritis with active inflammation in the medial layer of the artery. They excluded any patients who had isolated adventitial inflammation. So this is, as best we can tell, active arteritis that persists for many months despite our best efforts at treatment with current standard of care, that is glucocorticoids. So again, emphasizing the point that GCA is a chronic vasculopathy, at least when treated with our current strategy. So we continue to follow our friend Mrs. Smith, and she's now back for a 1-year follow-up visit. She's had a relapse a couple of months ago when she was on 10 milligrams of prednisone, and so you increased her prednisone to 20, and she feels better with that. But now she comes back in, her prednisone is back down to 12.5, and again she has malaise, symptoms of polymyalgia rheumatica. Fortunately, no headache or vision symptoms, but her CRP is significantly elevated at 53 milligrams per liter. So she's kind of getting tired of this, and she's asking, well, how many patients, is this normal? How many patients with this disease experience a relapse? And I'd like to get your thoughts about this. Is it none? Is it 10 to 20%? 30 to 40? 80 to 90, or, well, it depends. So I'm sure you'll appreciate that relapses are common in giant cell arteritis, but how common are they? So again, the majority, 10 to 20%. I think it's a little higher, and I would say 30 to 40, and I'll show you some of the data. Of course, the folks who answered E are also correct, because it also depends on how you define relapse, and there is yet no standard definition of disease relapse in GCA. Although in clinical trials, generally, a definition is used whereby patients have to have symptoms suggestive of GCA recurrence in combination with elevated inflammatory markers. So let's look at the data regarding relapses. This is a cohort that we looked at recently. And in this cohort, we saw that almost 75% of patients relapsed. But we were very generous with our definition of relapse, and we actually looked at all sorts of relapse by type. So we looked at patients who had symptoms and lab elevation. We looked at patients who had symptoms only with normal inflammatory markers, and then those who only had elevated inflammatory markers. And one could argue that, well, if you only have elevated inflammatory markers, that's not a relapse. But we also know from other studies that if you have elevated inflammatory markers in the absence of an obvious cause, like an infection, then they're often followed by a clinical relapse. So in clinical practice, we may tend to adjust treatment if there is persistent elevation of inflammatory markers. So we included all these sorts of relapses. If you have this broad definition of relapse, gosh, then it's almost 3/4 of patients will meet the definition of relapse. 1/3 had more than 3 relapses, so it's not uncommon to have multiple relapses. But half of the relapses, at least in our retrospective study, would meet the more stringent definition of relapse, which is symptoms plus lab elevation. So if you take half of 75, that's about 37%. And that matches other studies, a cohort from Spain, cohort from Italy, show that again, the rate of relapse is about 30 to 40% if you use the definition of symptoms plus elevated inflammatory markers. In clinic, though, we often deal with patients who have symptoms and normal markers, or again, elevated markers in the absence of symptoms. What do patients come in with? So the most frequent symptoms at the time of relapse are symptoms of polymyalgia rheumatica, so the typical aching and stiffness in the neck, shoulders, and hips, but headache and constitutional symptoms are also frequent. In these cohort studies looking at relapses, vision loss was not encountered, fortunately. In a prospective study from the Vasculitis Consortium, the relapse rate was, again, 34%. Interestingly, that those who have a relapse tend to have more relapses. Headache and PMR were the most common. And in this cohort, there was a low incidence of new vision symptoms at the time of relapse. But in this cohort, the definition of relapse was based on symptoms. And interestingly, there was 1/5 of relapses that patients presented with symptoms but had normal markers. And the study also tells us that the median prednisone dose at the time of relapse was 7.5 milligrams. So patients tend to relapse once we get usually below 10 or 15 milligrams of prednisone daily. So dealing with relapses is a big thing that we do when we're managing our patients with GCA. We're not very good at predicting who's going to relapse. At least in one cohort study, women tended to have a higher relapse rate. And individuals with cardiovascular risk factors, in this study hypertension and diabetes, at onset also tended to have a higher relapse rate during disease follow-up. In other studies, fever at the onset of illness, severe inflammation on biopsy, and anemia, again reflecting a robust inflammatory response at disease onset, were other predictors of disease relapse. In terms of managing relapses, of course, we have to exclude disease or other mimics, such as infection. We tend to increase glucocorticoids, and the amount of increase depends, of course, on the nature of the relapse. If it's PMR symptoms, we may go up maybe by 5 or 10 milligrams of prednisone. Fortunately, ischemic complications are uncommon, but in the setting of either cranial ischemic complications, vision changes, other complications like stroke or vascular stenoses, then of course we would have to resume the remission induction dosages with high-dose glucocorticoids. Imaging has not panned out very well in terms of predicting or assessing relapse, but certainly if there are symptoms of vascular insufficiency or signs of blood pressure discrepancy, then imaging may be necessary at the time of relapse. As you know, at least in terms of the current treatment landscape, disease-modifying agents, or I should say steroid-sparing agents for giant cell arteritis have been largely disappointing. Methotrexate is the best studied, evaluated in 3 clinical trials with discrepant findings. But in a meta-analysis of the 3 trials, 84 patients on treatment, 77 on placebo, it was shown that methotrexate, this was a meta-analysis using individual patient data, it was shown that use of methotrexate may reduce the risk of relapse by about 35% and the risk of second relapse. It will also reduce the exposure to glucocorticoids, but there was no reduction in glucocorticoid events. You'll also see from the curves that it takes 24 to 36 weeks of methotrexate treatment to start to see a divergence in those curves and a response to therapy. So a modest effect at best, and again, certainly leads the way to hoping for better and more effective treatment strategies. But in patients who have recurrent relapses, in patients who have glucocorticoid-associated adverse effects, use of methotrexate is certainly reasonable. We looked at this is only a retrospective study, again in a Mayo Clinic cohort, 84 patients on methotrexate and 84 controls, and we did see that there was a reduction in the relapse rate in patients on methotrexate, and the relapse rate in patients on methotrexate dropped more significantly than it did in those who are not on methotrexate. So again, another small piece of evidence that there may be a role for methotrexate, again, modest at best. What about adjunctive therapy for GCA? So when we're caring for these patients, we need to be aware of a number of epidemiologic studies now that have documented an increased risk of coronary disease as well as cerebrovascular events in GCA. And cerebrovascular events in GCA may occasionally be related to direct vasculitic involvement, especially of the posterior circulation, but may also be related to accelerated atherosclerosis from the inflammatory burden. There's some retrospective data, not always consistent, that low-dose aspirin may reduce the risk of ischemic events, and we generally recommend this for our patients. Looking at statins, of course, very beneficial with their lipid-lowering effects, but thus far, studies have not shown that they have a significant effect on the inflammatory disease in GCA. As you are all aware and painfully aware, the adverse effects from glucocorticoids are almost universal. In a recent, very well done, large cohort study of over 5,000 patients with GCA, there was a well-documented increased risk of bone-related complications, osteoporosis and fracture, as well as glaucoma, hospitalization for infections, serious infections, and diabetes. And therefore, these are all issues that we need to consider as we're evaluating and treating our patients with GCA to try to prevent bone loss as well as ocular complications and infections. Infection risk, other studies showing an increased risk of about 50%, particularly during the first few months of therapy when patients are on high-dose glucocorticoids. These could be a respiratory tract infection, urinary tract infection, sepsis, and so forth. Pneumocystis also occurs in GCA, and if it does occur, it's bad with a mortality of almost a third. And so in general, pneumocystis prophylaxis, again, while on high-dose glucocorticoids is recommended. We also see vascular complications in patients with GCA, again, in spite of our best efforts at treating these, and clinically, large vessel complications are under-recognized. Again, a very nice prospective cohort study looking at this documented that our clinical exam tends to underestimate the prevalence of vascular complications in GCA. And so when we're evaluating these patients, it's very important to assess pulses in all four extremities, to listen for bruits, particularly over the carotid and subclavian arteries, measuring blood pressures, definitely in both arms, and often if there is evidence of subclavian involvement, then lower extremity pressures may need to be assessed. And we often perform non-invasive vascular studies with Doppler to assess for perfusion in the upper and lower extremities. Vascular imaging certainly has provided a very useful modality to assess for these complications, either CT angiography or MR angiography. Here's an example of a patient undergoing non-invasive vascular studies. You'll see a discrepant blood pressure with an arm blood pressure of 102 on the right and 67 on the left, documenting left upper extremity arterial occlusive disease. One of the more challenging situations is if you have patients who have bilateral upper extremity arterial occlusive disease. So in this situation here, the patient's arm blood pressure was 84 on the right and 78 on the left, but her lower extremity pressures were markedly elevated at over 200. So she had unrecognized severe hypertension, unrecognized because of bilateral subclavian artery involvement from GCA. And again, this can be evaluated with non-invasive imaging such as CT angiography or MR angiography. Upper extremity involvement, typically the subclavian and axillary arteries, can be seen in the majority of patients with GCA if you look with sensitive techniques such as PET, but on CT angiography, about 42% in one study were shown to have upper extremity disease. Symptoms are less frequent, but again, this is something to watch for in our patients and to assess clinically. This is a patient with biopsy-proven giant cell arteritis who about 6 months or so into the course of her illness developed severe leg claudication, right more than left. She had markedly abnormal ankle brachial indices, again, especially on the right side, and she, on imaging, had long tapered narrowing of the superficial femoral artery on the right side, and perhaps some less severe involvement on the left, but certainly bilateral involvement. And in cross-sectional imaging, one could see the typical thickening that's circumferential around the SFA, consistent with vasculitic involvement. And after treatment with immunosuppression, had quite significant improvement and normalization of her ABIs. So apart from upper extremity involvement, lower extremity involvement in GCA is also possible, but certainly a relatively rare complication. So we're still following Mrs. Smith, haven't forgotten about her, and gosh, now 6 years have gone by, and she came back for a follow-up visit. She's in clinical and laboratory remission, and her physical exam is entirely normal. She has hypertension and she's developed osteoporosis for which she's on treatment, has been off of treatment for 2 years now. She's active, enjoys traveling, golfing, and leads a healthy lifestyle. What should we do next for Mrs. Smith at her 6-year follow-up visit? A transthoracic echo, a chest CT, a chest X-ray, a chest MR angiogram, or E, nothing else. So 6 years into the disease process, doing very well clinically, asymptomatic. And I'm curious to see your thoughts. Looks like most people would do nothing. Some folks want to get a chest X-ray, an MR of the chest. So there's no clear answer here. But I would disagree with E, and I would do some form of imaging study, mainly because of the increased risk of aortic aneurysm in these individuals. So population-based data suggests somewhere between a 6-fold and up to a 17-fold increased risk of thoracic aortic aneurysms in patients with GCA. In prospective studies, most recent one from Spain, the longer you follow up these patients, the more complications you pick up. So at 10 years of follow-up, the incidence of aortic aneurysm was 33%, so that a third is certainly not to be ignored. There are no consistent clinical predictors. There are some patients who have dilatation of the aortic root and may present with a murmur of aortic regurgitation. But otherwise, we're not good at predicting who's going to have this complication and who is not. Again, this is a late complication. This is from population-based data in Olmsted County, showing that the longer you follow patients, the higher the risk of detecting an aortic aneurysm. So this is a slow, generally a gradual process, usually when patients are in remission on no treatment. So there are various expert recommendations ranging from a chest X-ray, which has a very poor sensitivity for picking up an aortic aneurysm, but most experts would recommend imaging either with echocardiography, CT, or MR. Echo is advantageous in terms of having no radiation and is non-invasive. The American College of Rheumatology has no guidelines to date about this, but the American College of Cardiology and Society of Vascular Medicine do recommend actually a baseline imaging study in all patients with GCA. Part of this is because up to 15% of patients already have evidence of aortic damage at disease onset. Another elegant study from the UK, an epidemiology study, suggested that you only need to screen 5 to 10 patients with GCA with imaging to detect one previously unknown aneurysm or dissection. The most recent guidelines on the management of GCA come from the French Vasculitis group, and they recommend in their guidelines imaging every 2 to 5 years. So again, no clear guidelines here, but definitely an interest and a need, I think, to image these patients periodically with your imaging study of choice. The reason being is we want to try to prevent this complication, aortic dissection. There are a lot of unknowns about aortic aneurysm in GCA. We don't know the rate of progression of these aneurysms, and we don't really understand the optimal timing of repair. There's some preliminary data that these aneurysms may tend to dissect at smaller dimensions compared to degenerative aneurysms. So in conclusion, I have hopefully shared with you that giant cell arteritis is a chronic and systemic vasculopathy with potentially devastating complications. Our current treatment strategy, i.e. glucocorticoids, certainly has some advantages, particularly with regards to loss of vision, but many significant limitations and morbidity. There is a great unmet need in giant cell arteritis and large vessel vasculitis in general. We certainly await more targeted and effective therapy with less toxicity, and I believe that Dr. Merkel's talk is going to be much more optimistic than mine. Thank you for your attention.